going to give us the opposite view.
Okay, my slides are being loaded. Do you really believe what Joseph Gigorov told you? Really? I will demonstrate that he's wrong. I do have a beginning which is somewhat similar to his, because indeed in 2018 we are slightly different, and we were asked to debate about more systemic therapy after neoadjuvant. And I had this slide already last year saying that we would rather be in this place than in here. Obviously, we want to see Egypt, not only our friends from Egypt. And this was because last time we were sold in the so-called White Canyon Hall. So I was given the title of saying no need. I think everyone agrees that if something is not doing enough, we need to do something. So I changed this to no more blind systemic therapy, because my distinguished colleague just said, well, we have the answer, capecitabine. Oh, come on. That's not an answer. In St. Gallen, a few years ago already, Gunther von Winklitz said what we have been discussing, and this has been very nicely said by Joseph Gigorov, i.e. that PCR is a very important achievement. But he also said that we have to look at some different endpoints, and we have to discuss this. Yes, it is bad news not to have a PCR, and certainly it is very bad news if the disease is triple negative and the treatment. And Dr. Gligorov alluded to the fact that our colleagues in Japan maybe hadn't given an appropriate treatment before they gave capecitabine. So it's always good to rely on colleagues to make your point. It's not only me saying that Dr. Gligorov is wrong, it's also the distinguished team that has put together the guidelines of the German gynecological group on neoadjuvant systemic therapy, which are available to anyone online on the AGO website in German and in English. And if we look at what they tell us, they say a lot about what we believe about neoadjuvant therapy. And they certainly tell us at the bottom that this should allow individualization of the treatment. Not what you just heard, give them some more capecitabine, come on. That's not what we want. Yes, we do have some data from the German studies that in some specific settings, as shown on this slide with the levels of evidence that they provide to us, we could go in a certain way and believe that we are doing quite well by saying continuation with a non-cross-resistant regimen. But this is old style. We are in 2018. We need to work on this. So my plea is don't follow the simple answer, but try to be a little bit more scientific. One point that I would like to share once again with you, as I did last year, is that we do have evidence that when we are doing treatment in the adjuvant setting for triple negative, it is not only about the intensity of treatment, and you are all aware of still not published and maybe somewhat debatable meta-analysis that indicate the importance of dose intense, whatever is called dose intense treatment in the use of chemotherapy. but also about the delay, because many say, well, we don't really know whether in triple negatives we should start actually before surgery or after surgery. But there are lots of studies that point to the fact, including a very old subset, yes, a subset analysis of NSABP studies saying that in younger women, as it was said at the time, with triple negative, it might be very important to start earlier than later. So a classic way of looking at the advantage of neoadjuvant is on this slide, and I used it last year, and I'm going to modify it for you. Because instead of having the evaluation when the patient has no clinical response by asking the surgeon to come, or just simply changing the regimen, let's try to look at what could be done. Let's develop the studies using maybe solid biopsies or also liquid biopsies, both of them together, give more neoadjuvant therapy according to those data, and then monitor the effect, and not just simply find that capecitabine is a good answer. Actually, this is not something that I'm the only one to tell you. I'm asking here for the help of Eric Weiner, who discussed this at the San Antonio meeting in 2016, and this is a slide that he provided for those who attended the San Antonio meeting, and which was again taken up by Reagan at a very nice discussion at the St. Gallen, now Vienna meeting in 2017, saying exactly what I'm telling you. If there's no PCR, patients should go into a study comparing a standard approach, let's say capecitabine, to experimental treatment. What do our German colleagues say? Well, they say something like this, because what they tell us, if the patient doesn't have a complete pathological response of adequate treatment before the evaluation, capecitabine has a level of evidence 2B. The grade of recommendation is B. It's not really into clinical practice. It's plus or minus. So yes, it's worth thinking about it, but this is what impressed everyone when it was presented in San Antonio. Difference in overall survival. Aha, very, very important indeed. But Dr. Gligorov didn't discuss with you the fact that, look at these curves. They are now in the final publication in New England Journal of Medicine starting to get together. So is capecitabine really making a difference? Is it not really making a difference? Now, for scientific reasons, please remember this is a debate, and I'm not completely fair. I have to be unfair. I'd like to attract your attention to the fact that there are many other possibilities that are available, and as I did last year, please read this very nice editorial from Erika Meyer and Skip Bursten, which was in the JCO in 2016, discussing an approach suggested by my friends from the European Institute of Oncology in Milano on metronomic chemotherapy. So, my dear colleagues, I believe that you're much too bright to agree with Dr. Gligorov. No more blind systemic therapy is the answer. Join Eric Weiner, others, and myself saying Gligorov is wrong. Thank you very much for your attention.
Thank you very much, Professor Aapro, for this point of view. By the end. No, by the end, by the end.